So guys, welcome back. Today we are going to deal with pathogenesis, clinical feature, differential diagnosis, treatment of retinal detachment. Okay, retinal detachment. It is nothing. It is doesn't mean that retina is detached. Okay, we divide into definition, classification, pathogenesis, examination technique, clinical feature, differential diagnosis, treatment. Okay, remember this pattern while writing in exam. First, coming with the definition. Okay, separation of sensory retina from retinal pigment epithelium by subretinal fluid. Okay, this is very compressed type. It is nothing but retinal pigment epithelium and sensory retina are far because of subretinal fluid. Okay, classification. There are three types, that is rhegmatogenous. Another one is non-rhegmatogenous. In that, two types, tractional and exudative. Okay, you can write three types also: rhegmatogenous, tractional retinal detachment, exudative retinal detachment. Okay, first coming with rhegmatogenous retinal detachment occurs due to full thickness defect in sensory retina. Okay, and subretinal fluid from liquefied vitreous enters into subretinal space. Prevalence is 1 in 10,000 eyes. 10,000 or we need tens, 100,000, 10,000. Okay, 10,000 eyes, more common in myopes. Okay, imagine this is retinal pigment epithelium, and here we have neurosensory retina here. Okay, here we have neurosensory retina. Here in between we will have subretinal fluid. Okay, this is retinal detachment, remember. And rhegmatogenous means complete neurosensory retina. Okay, complete neurosensory retina is gone. Okay, like this, complete neurosensory retina is gone, and in between we will get fluid now here. Okay, between neurosensory retina, because complete defect in neurosensory retina here. This is it should be like this, but there is complete defect. Okay, tractional retinal detachment. Uh, okay, in tractional retinal detachment, sensory retina pulled away from retinal pigment epithelium by contracting vitreoretinal membrane. Okay, traction, because contraction of vitreoretinal membrane causes are proliferative diabetic retinopathy, retinopathy of prematurity, sickle cell retinopathy, penetrating posterior segment trauma. Exudative retinal detachment. Okay, fluid derived from choriocapillaries. Exudation from choriocapillaries. Okay, exudation from choriocapillaries gain access to the subretinal space to the retinal pigment epithelium. Causes choroidal tumors, exophytic retinoblastoma, Harada's disease, toxemia of pregnancy, posterior scleritis, subretinal neovascularization. Pathogenesis of rhegmatogenous detachment is underlying mechanism. First is retinal breaks. Okay, I already said there will be complete break in neurosensitive retina. Okay, vitreous traction. Retinal breaks occurs in 5 to 10% of the population. 70% of breaks are located superiorly between 10 o'clock to 2 o'clock position. Okay, mechanism of rhegmatogenous detachment is liquefied vitreous, posterior vitreous detachment, retinal breaks, failure of retinal pigment epithelial pump. Okay, this thing, fourth point, failure of retinal pigment epithelial pump. There are few pumps like located, like sodium, potassium, some kind of pumps are there. Those pumps fail to push that subretinal fluid back to their place. Okay, because of that there will be accumulation of fluid. Okay, here in this diagram you can see pressure exerted by the detached vitreous gel. Site of abnormal vitreoretinal adhesion, subretinal space, there will be fluid deposition, and direction of liquid passing into the subretinal space. Okay, liquid is going into subretinal space here, and liquid vitreous posterior to the vitreous gel. Okay, vitreous gel. This is a very beautiful diagram explaining rhegmatogenous retinal detachment. Next, coming to tractional retinal detachment, vitreous traction tears the retina. Formation of vitreous membrane, contraction of fibrous bands, bleeding induces fibroblastic proliferation, band pull the retina, traction detachment sets in. Okay, something is pulling, that is vitreous traction. Okay, something is vitreous traction, which causes contraction of fibrous bundles. Bleeding causes fibroblastic proliferation. Okay, exudative retinal detachment, causes of the tumors of the retina and inflammatory diseases due to damage to the retinal pigment epithelium, allows fluid to leak into the subretinal space. Okay, it will come from backside, exudative. Examination techniques are direct ophthalmoscopy, indirect ophthalmoscopy, Goldman 3 mirror test, slit lamp examination with the plus 78 and plus 90 lens, and next is B scan ultrasonography. Okay, clinical features of rhegmatogenous detachment are: symptoms are variable, photopsia, metamorphsia, shower of black spots, cloudy vision. Okay, signs of rhegmatogenous detachment are Schaffer sign. First sign is Schaffer sign. Okay, slit lamp examination shows there is fine pigmented cells of tobacco dusting on the anterior face of the vitreous or in anterior chamber with no previous eye disease, trauma, surgery or inflammation. Okay, fine pigmented cells or tobacco dusting on the anterior face of the vitreous in the anterior chamber. Okay. Diagnosis of retinal breaks. Detached retina presents as white or gray discoloration folds and which oscillates on ocular movement. Okay. There will be retinal break. This word is important. Retinal vessels crossing over detached retina look darker. Okay. Peripheral lesions require scleral indentation. Breaks will be seen on low intraocular pressure. Visual fields like scotoma, corresponding area of the detachment. Electroretinogram, it will be subnormal or absent. B scan reveals detachment. Okay. You can see horseshoe shaped tear of retinal of the in this, and you can see old retinal detachment. Okay. Horseshoe shape shows marked pallor of the detached retina. This is a subretinal vacuole scene. Okay. Clinical features of exudative detachment are detached retina, convex smooth surface, no retinal break, shifting of subretinal fluid on head movements. Okay. There will be shifting of subretinal fluid, diminution of vision, black floaters, no photopsia and fundus. Fundus smooth convex gray discoloration is seen, no retinal breaks. Raised intraocular pressure if associated with tumors. Visual fields that is scotoma is seen. Okay. And transillumination negative if due to the tumors. Transillumination means light you will put from one side, can be seen on other side. These are the clinical features of exudative. Okay. Detached retina, no retinal break is seen, shifting of subretinal fluid, diminution of vision, black floaters, no photopsia, raised intraocular pressure if associated with tumors, transillumination is absent. Visual field that is scotomycin. Clinical features of tractional retinal detachment is smooth surface, usually taut and immobile, and concave towards the in front of the eye, usually limited to the posterior fundus. Breaks are usually absent. Okay. To differentiate various types of retinal detachment, okay, we will see differential diagnosis. Senile retinoschisis and choroidal detachment are differential diagnosis. Okay, let's in senile retinoschisis there will be separation between inner nuclear and outer plexiform layer. Okay. But in retinal detachment, there is separation of retinal pigment epithelium from nerve fiber layer. Okay. Common in lower temporal bilateral smooth thin convex elevation, immobile and transparent inner layer, and no demarcation line, absolute field defect. Okay. In choroidal detachment, separation of retinal pigment epithelium and choroid due to fluid or blood in the subchoroidal space. Okay. In choroid detachment is because of fluid in subchoroidal space. Smooth brown dome-shaped elevation and bullous, very low intraocular pressure. Ora serrata can be seen with scleral depression. Okay, these both are extra things. Okay, this is choroidal detachment. Here choroidal detachment is there. Okay. What are the differences between retinal detachment and choroidal detachment? Retinal detachment will be color will be pale. Okay, in choroidal detachment it will be darker or normal color. Dome that is convex coagulated, it will be convex smooth. Okay. Breaks are present, here breaks are absent. Ora serrata visible with indentation, it is easily visible. Choroidal detachment is easily visible. Okay. Maximal extent is anterior up to ora serrata and posterior is unlimited. Okay. Here anterior up to the ciliary body, posterior up to vortex veins. Okay. Goals of treatment is identify all retinal breaks, close all the breaks, place scleral buccal to support all retinal breaks. Retinal tear should be flat on buccal. Okay. Treatment of fragmentogenous retinal detachment. Seal and support the break. Sealing can be done by cryopexy, photocoagulation, and diathermy. Okay, remember these three words: cryopexy, photocoagulation, and diathermy. Scleral buccal supports the break by reducing the vitreoretinal traction as well as the opposing retinal pigment epithelium to the sensory retina. Retinal detachment with vitreoretinal traction and proliferative vitreoretinopathy requires pars plana vitrectomy. Okay, pars plana vitrectomy, and this is another one you should remember. Prophylactic photocoagulation or cryopexy is recommended in high myopia with lattice degeneration holes in ora serrata. Okay. So remember cryopexy, photocoagulation, and diathermy, and pars plana vitrectomy. Okay. Treatment is by scleral buckling, drainage of subretinal fluid, intravitreal injections, pneumatic retinopexy, pars plana vitrectomy. Okay. These things you should remember mainly. If you don't remember upside also, these things are must to remember. Scleral buckling, drainage of subretinal fluid, intravitreal injections, pneumatic retinopathy, and pars plana vitrectomy. Okay. Scleral buckling. Okay. It is a surgical technique for creating an inward indentation of the sclera. Explant in material directly sutured due to the sclera to create a buccal. Okay. This is the buccal. Okay. A, B, C, D are the different buccals put so that you can further prevent the retinal detachment. Okay. These are the types of scleral buckling. Types of explants are radial explant, placed right angles to the limbus, circumferential explant, segmental or encircling, silicone sponges, that is hard and soft. Okay, these are the types of scleral buckling. Radial sponge, circumferential sponge, the A, B, C, D. Okay, first is radial. Okay, this is radially kept like this, radial. Next is circumferential, means it is kept in circumferential, and circumference with a radial sponge, and circulatement with a solid silicone tire. Okay. Intravitreal injections of air, saline, expanding gases, silicone oil, and perfluorocarbons can be given. Okay. One thing you remember, if you put something if the person went in aeroplane, okay, there will be different thing. Okay, because the pressure will be different on the atmospheric pressure and in the aeroplane. Okay, that's why. Pars plana vitrectomy. Indications: tractional retinal detachment involving fovea. Selective rhegmatogenous retinal detachment with breaks which cannot be closed by conventional methods. Treatment of exudative retinal detachment is by may undergo spontaneous resolution, follow absorption of the fluid. Treatment of ocular inflammation or neoplasm. Okay. In exudative, there will be some kind of neoplasm like retinoblastoma. You should be get treated. Okay. Treatment of tractional retinal detachment because of traction. Traction pull is relieved by segmentation or delamination. The epiretinal membrane can be removed by peeling during pars plana vitrectomy with prophylactic encircling. Okay, peeling during pars plana vitrectomy. What are the let's us differentiate all three. Okay, history. Rhegmatogenous retinal detachment will come with photopsia, floaters, field defect, pseudophakia, myopia, blunt trauma. In tractional, because of diabetes, prematurity, penetrating trauma, venous occlusion. Exudative because of malignancies. Okay, hypertension, eclampsia, renal failure. Retinal break is seen only in rhegmatogenous detachment. Okay, in tractional detachment, no primary break is there. May develop secondary break. Okay, in exudative, no break is seen. Extent of detachment extend up to the ora serrata. Okay, rhegmatogenous can extend up to ora serrata. Tractional detachment frequency does not extend to ora serrata. Exudative is variable. Okay, retinal mobility undulated folds. Okay, and in tractional, taunt retina will be there, concave borders. In exudative, smooth elevated bulle type is there. Okay. Configuration is convex, concave in traction. Okay, concave in tractional and convex in exudative. Vitreous pigmentation. Vitreous pigmentation is present in rhegmatogenous, present in traction and absent in exudative. Okay, vitreous changes. Posterior vitreous detachment. Here will be vitreoretinal traction and not present in exudative. Okay, causes are retinal break. Okay, and in tractional retinal detachment, it is because of proliferative diabetic retinopathy, vasculitis, retinopathy of prematurity. Okay, in exudative, it was because of uveitis, choroidal melanoma or hemangioma, VKH, that is walked Konagami Harada syndrome, and retinoblastoma. Okay, this is the three difference. Okay, with this we will end retinal detachment. Bye. Jai Hind, Jai Bharat.